Common questions about colorectal cancer screening. Why is colorectal cancer screening important? Colorectal cancer is one of the most common cancers in the world. Many patients with colorectal cancer are diagnosed at stage 3 or later, which is associated with poor survival. Colorectal cancer can arise from colorectal adenomas, giving rise to the classic adenoma-carcinoma sequence of pathogenesis. It takes an average of about 10 years for an adenomatous polyp to develop into invasive cancer. This long period of progression from polyp to cancer provides the rationale behind CRC screening. It allows detection and removal of adenomas or early-stage colorectal cancer that is asymptomatic. How is colorectal cancer screening done? Screening tests for colorectal cancer include stool-based and direct visualization tests. There are 3 types of stool-based tests. They are guaiac-based fecal occult blood tests or FOBT, fecal immunochemical tests for hemoglobin or FIT, and multi-targeted stool DNA tests FIT-DNA. Both FOBT and FIT detect the presence of components of hemoglobin in feces. There are 3 types of direct visualization tests. They are colonoscopy, CT colonography and flexible sigmoidoscopy. What are the pros and cons for each type of stool-based test? FIT uses antibodies raised against the globin moiety of human hemoglobin and has improved sensitivity compared to FOBT for detecting colorectal cancer. Moreover, the advantages of FIT over FOBT are that it has increased specificity, as the antibodies bind only to human globin. It is not confounded by blood loss proximal to the colon. It is unlikely to be affected by antioxidants such as vitamin C or vegetable peroxidases. It requires fewer stool samples, and analysis can be automated. FIT-DNA is an emerging screening technique that combines FIT with testing for altered DNA biomarkers in colorectal cancer cells shed into the stool. It has increased sensitivity but lower specificity than the use of FIT alone. All the stool-based tests are done yearly. What are the pros and cons for each type of direct visualization test? Colonoscopy is considered the gold standard test for colorectal cancer screening. It covers the entire colon and thus requires less frequent screening. Colonoscopy is done once every 10 years for average-risk patients. Screening and therapeutic follow-up on positive findings can be performed during the same examination. The diagnostic accuracy and therapeutic safety of colonoscopy depends, in part, on the quality of the colonic cleansing or preparation. Hence, it is important that patients are educated and engaged in the colonoscopy preparation process. Risks of colonoscopy are and include sedation-related adverse events, perforations and major bleeding. Flexible sigmoidoscopy examines the distal part of the colon, and does not detect lesions on the proximal and transverse colon. It is done once every 5 years for average-risk patients. It is potentially an attractive option for patients who want endoscopic screening but prefer limited exposure to colonoscopy and want to avoid the full bowel preparation regime. CT colonography is minimally invasive imaging of the entire colon and rectum. It is done once every 5 years for average-risk patients. Radiation risk is a relative disadvantage of CT colonography. Incidental extracolonic findings are common. Concerns remain over the potential harm that may be associated with overdiagnosis and overtreatment of incidental extracolonic findings. Age: what age should patients start colorectal cancer screening? It depends on the risk profile of the patient. Individuals can then be stratified according to their risk factors into average, increased and high-risk groups. Average risk is defined as no family history of colorectal cancer, and no personal history of adenomatous polyps, sessile serrated polyps, colorectal cancer or inflammatory bowel disease. Increased risk is defined as having a personal history of adenomatous polyps, sessile serrated polyps, colorectal cancer or inflammatory bowel disease. Family history of one first-degree relative with colorectal cancer at less than 60 years of age, or two first-degree relatives with colorectal at any age. First-degree relative with confirmed advanced adenoma. First-degree relative with colorectal cancer at more than 60 years of age. One second-degree relative with colorectal cancer at less than 50 years of age. High risk is defined as having a personal history of inflammatory bowel disease. Presence of high-risk syndromes such as hereditary non-polyposis colorectal cancer or polyposis syndrome. For average risk individuals, screening should commence at 50 years of age. The guidelines emphasize shared decision-making, a process in which the physician and patient share information, then reach a shared medical decision about the screening test that is best for the patient. Individuals with increased risk of colorectal cancer should have personalized screening strategies. In particular, for those who have an affected first-degree relative diagnosed before 60 years of age or two first-degree relatives with colorectal at any age, colonoscopy is recommended every 5 years, beginning 10 years prior to the earliest diagnosis in the family or at 40 years of age at the latest. Individuals who have a first-degree relative with a confirmed history of advanced adenoma should undergo colonoscopy at the relative's age of onset of adenoma, or by 50 years of age at the latest. For those with one affected first-degree relative diagnosed at 60 years of age or older, or one second-degree relative diagnosed prior to 50 years of age, colonoscopy should begin at 50 years of age. High-risk individuals must be referred and co-managed by a gastroenterologist, colorectal surgeon and cancer geneticist for regular and active surveillance of colorectal cancer.
Audio Jungle. Audio Jungle.